1974. A founding member of the Woodstock Theological Center in 1974, Father Hoy was senior fellow until 1984, and again from 2004 to the present. At Woodstock, Father Hoy coordinates Woodstock's Catholic Higher Education Project, and in 2007 won the Monica K. Hellwig Award from the National Association of Catholic Colleges and Universities for outstanding contributions to Catholic higher education. Father Hoy has authored several books, including Where is Knowing Going? The Horizons of the Knowing Subject, which was awarded the 2010 Catholic Book Award in Education from the Catholic Press Association of the United States and Canada, Housing Heaven's Fire, The Challenge of Holiness, Virtue and Affluence, The Challenge of Wealth, Converting 9 to 5, A Spirituality of Daily Work, The Holy Use of Money, Personal Finance in Light of Christian Faith, and The Conspiracy of God, the Holy Spirit in Us. He has also edited In Search of the Whole, 12 essays on faith and academic life, revisiting the idea of vocation, theological explorations, personal values in public policy, conversations on government decision-making, and The Faith That Does Justice, examining the Christian sources for social change. Next is Corinne Parver. Initially trained as a physical therapist at McGill University, Corinne Parver practiced for 15 years prior to completing her legal education at American University, Washington College of Law, cum laude, in 1982, where she was an assistant editor of the Law Review. A distinguished legal career focused on health law followed, including her having served as a healthcare associate attorney, in-house counsel at a professional organization, director, vice president, and later president and CEO of a national healthcare trade association. She was also a partner and head of the health law services practice at the Washington, D.C. law firm Dick Stein Shapiro. After retiring from the law firm in 2004, Ms. Parver designed the health law specialization for the American University Washington College of Law's LLM program on law and government, and expanded the health law curriculum so that the law school now offers from 15 to 20 health law policy-related courses each academic year, including the annual Summer Health Law and Policy Institute, which she established in 2008. She has extensively published, testified before congressional committees, and lectured in the United States and Canada on healthcare topics during her career. Ms. Parver served as the faculty liaison to the Health Law and Justice Initiative, the Law Students Health Law Association, oversaw and edited the law school's Health Law and Policy Brief, and taught 1 to 2 health law courses per semester. She retired from the faculty of the law school in July 2011, and in her retirement is spending time volunteering in the healthcare industry as a member of the Board of Trustees and Executive Committee of Holy Cross Hospital in Silver Springs, Maryland. And then Mr. Robert Stanek graduated from the Philadelphia College of Pharmacy and Science with a Bachelor's of Science degree in pharmacology, and later earned his master's in business administration with a focus on administrative management at St. Joseph's University in Philadelphia. He has extensive experience with multi-hospital systems and corporate organizations with 24 years experience in Catholic healthcare, having served in various executive positions in several Catholic hospitals and health systems. Most recently, he has served as Executive Vice President and Chief Operating Officer for Catholic Healthcare East, and then as its President and Chief Executive Officer from 2003 until his retirement in 2010. Mr. Stanek has served as a member of numerous boards of health associations, executive committees, and civic organizations such as the United Way of Erie County, Canisius College, and the American Red Cross of Northeastern Pennsylvania. He was guest lecturer in the MBA program at St. Joseph's University and has received numerous awards, such as the Community Service Award from the American Heart Association, the Merck, Sharp & Dome National Pharmacy Leadership Award, and the President's Award for President from the National Association of Retail Druggists. Mr. Stanek has been a member of the Board of Directors of the Catholic CEO Healthcare Connection, a national forum of Catholic health system leaders, since 2004, and he is currently serving as chair of the Board of Trustees of the Catholic Health Association of the United States. His experience in integrated healthcare system development, his demonstrated skills in collaborative planning and consensus building, and his years of commitment to the Church's healing ministry give him a unique perspective in assessing the future directions of Catholic healthcare. And so let's welcome our panelists today. And so we'll begin with Father Hoey, who will give us some reflections on the mission of Catholic healthcare.
They'll be brief because of the expertise of my other two panelists. What I find interesting in the discipline of theology is the subset which is called missiology. So theological missiology, what is the mission of the Church, I think really comes down to one word. And all of the energies of the Church and all of the institutions of the Church can all be reduced to that one word, which is healing. God's mission in Christ through the Spirit is a mission of healing. Putting together what we tend to separate, as Barbara said in her talk, the secular and the sacred. If we were good at putting together the secular and the sacred, we would see that what is going on in a hospital, more pointedly and specifically and formally a Catholic hospital, is a process of healing. A healing can be spiritual or physical. The hope of a healthcare facility is that the healing will be physical. But having been around for a while as a priest, and having heard many comments about the care that people are given in hospitals, specifically Catholic hospitals, I'm very aware of the healing that frequently takes place as a result of the presence of something which may be named religiously or not religiously, Christianly or not Christianly. Je ne sais quoi about there's a presence here. There's something special here. It may be more evident in the CEO or the person who mops the floors, but something special that suffuses the hospital. I think we have to overcome the pious nostalgia of seeing goodness in past charismatic figures and in past charisms. Barbara was covering the beautiful story today of religious women in healthcare, a beautiful story. But the presence of a charism is an enhancement of a human capacity to serve. The presence of charisms, especially the primordial example of charisms, which was Jesus, the presence of charisms are still evident to those who can behold them in health care. A Catholic hospital is a matrix of charisms. And frequently the source of the charism is in the science or the technologies that are being used in the healthcare system. The word charism is not a frequent word in, at least in Catholic speech. It should become a more frequent word because the way the Spirit governs the world and gives order in the world and gives well-being in the world, insofar as we can see any of these in the world, I think can be traceable to the Spirit. And it would be helpful if Catholic hospitals could see the matrix of charisms operating in the healthcare efforts that it enacts. I think in many ways Catholic healthcare can teach the Church who she is and what her mission is. Even though many of the caretaking personnel would not name themselves even in religious terms. All knowledge is healing knowledge. And the kind of knowledge that goes into taking care of patients today is exponentially greater than the knowledge that went into taking care of patients in every yesterday. So the sources of that knowledge I want to trace to God. Whether the people who are coming up with those scientific findings, say in pharmacology, even know that they have any indebtedness to God in the talents that they bring to their prowess, or even if they're not in healthcare, maybe just the sciences and technology. Tim Godfrey, who introduced me and the rest of us today, we have a friend within a mile here. His name is Rick Curry, who was at death's door a couple days ago and is the most recent witness to the minds and the hearts of at least the two of us about the matrix of charisms that are required to bring people from sickness to health. It's an incredible recovery that he's had, and one that we hadn't expected. So I'm just I just want to bear witness to the importance of Catholic health care and the way I see the abilities that tumble into its mix and the importance to see it as going all the way back to the healing Christ. 20% of the Gospels are stories about healings. There are 41 healings in the Gospels. And I just think it would be, it not only would be edifying, I think it could be, think it could engender a lot more energy in the drudgery, the day-to-day drudgery of healthcare, if it could be traced back to the person of the healing Christ, who came into the world to manifest to the world God's intentions for the world, and God's intentions for the world are to make it whole and make it one in the unity of the Holy Spirit. So these are not pious sentiments to me. They're very heartfelt sentiments. Thank you.
Is your microphone on, Corinne?
It is. Maybe I should bring this closer. Is that better? No, it's not.
Yeah.
Green light is on. Switch. How's that? Better. See,
That's good.
it was on, but it's not working.
Now, Corinne will offer her perspectives as being on the member with the trustees at Holy Cross Hospital, and some reflections in terms of her experience there, as well as on policy development.
Thank you, but I will be speaking just for myself, not for Holy Cross Hospital or American University's Washington College of Law. I still serve as a consultant to them as they transition from my founding of the Health Law and Policy Program to the three people who are taking over my role, which always makes me laugh. But what I'd like to do is go back to something that Barbara touched on in the beginning of her presentation, the Affordable Care Act, a couple of provisions regarding coverage, and then sort of pose a lot of questions to us because of the holes left with the lack of coverage for everyone. And then tell you a little bit about how Holy Cross Hospital is taking its resources to expand services for the broader community that it serves. And in that way, hopefully getting back to some sense of spirituality from the kind of mundane of laws and regulations brought about by the Affordable Care Act. So we do see in the overall coverage approach some shared responsibility with the individual mandate that everyone has to purchase some kind of health insurance. Now, we do know that this particular provision of the law is coming under very intense scrutiny, with the Supreme Court having decided to spend 5.5 hours of oral testimony pretty soon in hearing whether or not the individual mandate is constitutional. It's anticipated that the decision will come out in June, but you know, if it does remain intact, then we will see increasing coverage due to that mandate, and some penalties on the part of employers if their employees have to get a subsidy. There's a small employer exemption. You will see an expanded Medicaid program, and we all know that the states are suffering financial deficits these days, so we have to think of, well, if Medicaid is expanded, where will that money come from to help the Medicaid recipients? There'll be some new tax credits, some additional subsidies, more regulations of insurers, both in the long term and short term, and creations of state exchanges for people to purchase their health insurance. It's anticipated that coverage will be increased from 8 to 10% starting in 2014, and increases in total national health care spending will only increase up to 2 to 3%. So all that is pretty good news. What I see as really the most disturbing news is that by 2019, only about 60% of the uninsured will be covered. That is a decrease from 54 million to 23 million, but it still leaves over 30 million people lacking health insurance. So with the implications of more coverage, with still 40% of the uninsured remaining without health insurance coverage, that poses significant problems, but on the flip side, opportunities for Catholic hospitals in the way of providing more community benefit, and I'll talk a little bit more about that in a short while. Larger employers, are they going to continue providing health insurance as they do today? There have been some studies that have shown that some major employers are not going to continue to offer health insurance coverage as part of their benefits for their employees. Well, what will happen to those employees? Will they be, if there is an individual mandate, will they get help to purchase health insurance through the exchanges? If they don't get help and they don't have sufficient funds, how will they obtain their health insurance? And what burden will that place on Catholic health care? There's ongoing pressures to limit public and private spending. What's going to be the governmental response towards very tight fee-for-service payments and physician reimbursement? So with that sort of brief description of my concerns with the Affordable Care Act, what I'd like to tell you about is what Holy Cross Hospital has been doing over the past several years with respect to community benefit, as sort of a guide to those of you who are here from other hospitals as to what you may be able to do, and with you here from the Catholic Health Association, maybe give a hint to some of your other members. Looking at the difficulties within Montgomery County, where we're close to, the Holy Cross Hospital has decided to continue to serve the underserved and the vulnerable populations by delivering community care. We are operating, I say we, because I can't always take my hat off, but Holy Cross Hospital is operating 2 health centers for uninsured adults, and they are building and equipping a 3rd center in Aspen Hill that will open this year. And what the hospital has done is it has taken several disease processes and came to decisions as to what community benefit can be accomplished for these disease processes. In looking at cancer, there is a minority and community outreach program and a mammography assistance program that also goes to breast education, self-examination, screening, biopsies, ultrasound, surgery. And the number of mammograms and the number of breast cancers found a decrease in breast cancer incidence and mortality rates. Diabetes, leading cause of death for African Americans and Black women, and the outreach that the hospital has decided to do is to have these health centers in Silver Spring and Gaithersburg with a diabetes prevention program and a chronic disease self-management program. The hospital is measuring its method of evaluation and looking at the number of visits and the progress on 10 diabetic indicators, with pre-diabetics advancing to diabetics and a reduction in hospital admissions and readmissions. The third disease process, heart disease and stroke, which is a leading cause of death. Half of seniors have high cholesterol levels. What's the response to the community need? Community fitness programs, senior fitness in the health centers in Silver Spring and Gaithersburg. And assessments are being done on a semi-annual basis with progress measured on 10 heart failure indicators. Fourth, exercise, nutrition, and weight. 50% in the county, Montgomery County, are either overweight or obese. Programs, community fitness, Kids Fit, with a semi-annual fitness assessment. And finally, maternal and fetal and infant health. Opportunities to improve maternity care processes and outcomes. What is the community benefit? OBGYN clinics, maternity partnership programs, perinatal community education classes, home care follow-up for babies discharged from neonatal intensive care units. So there's, this is just a small little example of what one hospital, local hospital, has done in a response to health problems within Montgomery County. And I use that as sort of a teaching tool for what others can do to help ensure that those who aren't covered under the Affordable Care Act can receive care at little to no cost.
Now, Mr. Stanek will give us some insights into the future of Catholic healthcare, where it might be going. Thank you.
Thanks very much, Tim. I appreciate it.
Does yours work?
Are we okay?
No. Okay. It's called pass the mic.
This mic will be moving a lot around, I think. Let me sort of frame some thoughts of where the future of Catholic healthcare will go based upon maybe just a few very brief insights on the past and the present. Because I think, as Barbara said earlier, you know, you really need to know where you were until you identify where you want to go. Father said earlier that our healthcare ministry is really based in the healing mission of Jesus, and that really is our foundation. It really is founded by that healing mission and ministry, and I would suggest, particularly for Catholic healthcare in the United States, there is truly also a very special predilection for those who are poor. Because without that special predilection, especially in today's modern healthcare environment, we would have a very difficult time differentiating ourselves from other not-for-profit healthcare. Because in fact, that is our reason for being, if you will. You know, the Ursuline sisters in 1727, you hear some arguments about this, and Barbara, you're the historian. At least what I found, they're the first group of sisters who came to the United States, and they started a hospital for the poor in New Orleans. By 1875, there were 75 Catholic hospitals in the country, and I would suggest the vast majority of those, again, were based around women religious. Today, Barbara used the number of 1 out of 6 patients who are treated at Catholic acute care hospitals. We do account for about 20% of hospital inpatient admissions in 22 states across the country. So again, Catholic healthcare is a very, very significant portion of healthcare within this country. Presently, the historic standalone acute care institution in the Catholic world has been replaced to a very large degree by Catholic healthcare systems. Approximately 80% of all Catholic hospitals today are members of a Catholic healthcare system. And it's a pretty significant one. If, and I don't have this for you. If you want the data afterwards, I can provide it for you. But there are about 15 Catholic systems comprising within the top 40 healthcare systems, for-profit, governmental, not-for-profit, in the country. Very, very sizable acute care organizations. Probably the thing that's unique with Catholic healthcare and probably most similar to the for-profit sector is many of the Catholic healthcare systems are multi-state systems. They reside in many states up and down the coast. The Catholic Health East, the system that I was affiliated with, we actually had healthcare ministries in 11 states up and down the East Coast. So that's probably one of the distinguishing factors between not-for-profit and Catholic healthcare from a system perspective. From a statistical perspective, I would suggest that hospitals, sponsors, whether they're women religious or dioceses, all have remained relatively static since the mid-1960s. Little drop-off of acute care hospitals, but by and large, nothing overly dramatic. There is probably one statistic, and I'm going to talk about that when we speak about the future in a moment, that is very telling. In 1968, there were 770 hospital religious administrators or CEOs in the country. Today, in 2011, there are 8. I mean, it has changed that dramatically. The other suggestion I would make to you is over that period of time, religious moved from the C-suite into the boardroom, where women religious were very, very active on the governance level. And I would suggest still continue to remain active. But I'll share with you an anecdotal story. Catholic Health Association conducted a meeting for sponsors across the country in Albuquerque about 3 weeks ago. And there were about 150 to 175 individuals at that meeting. So it was a sizable meeting. And if you looked at that room and your mental model still was sponsors equal religious, I would suggest to you about 70% of the attendees were members of the laity. So it's not only changing at the management level, it's changing at the governance level, and it's changing at the sponsorship level. I'm going to talk about that in the future because that has a very significant, I believe, implication on the Catholic ministry going forward. So with those few statistics as background, let me give you a couple of comparisons as to maybe where we are now and where we probably are going to be evolving, at least from one person's perspective. And this is only one person's perspective going forward. Some of these are probably things that will be pretty intuitive to you, and others may surprise you a little bit. Someone used the terminology before, mission and margin and mission, and certainly in our current healthcare delivery system, if you don't have a margin, your ability to conduct your mission is compromised. I would make a suggestion, though, to you going forward, and that is, yes, it's no margin. Yes, without a margin, you can't have a mission, but I would suggest to you the mission always must be the dominant of those two. Because without that mission foundational orientation, then we become very, very quickly more similar to other healthcare providers than I think is consistent with who we are. Now that's really a challenge. Someone asked the question about maternity services at Mercy Hospital in Norristown. That was one of our hospitals. And I'll tell you what was really behind that. It was really came down to a conclusion that if maternity services were maintained, it was very likely that the entire ministry would be put at risk. And you know you have to weigh that. You know, what is the greater good? Now, what the institution replaced it with, albeit not direct maternity services, were prenatal ambulatory services, referrals to other organizations that provided OB, to literally do whatever you could short of an actual inpatient facility. Not the same, but at least the evolution into something that you can maintain the rest of the ministry in one fashion or another. The other comment I would make is those decisions, when they are made, and I would suggest to you that most of the, in fact, all of the large healthcare systems use some type of a formalized ethical decision-making process where you literally go through a very definitive process that's dialogic, that's reflective, that helps guide, if you will, when you have to make a very difficult decision, how you get there. Never easy, absolutely never easy, but the processes we use. Barbara used the vision of the wagon train taking the sisters to Iowa. And I would suggest when they went to Iowa, it wasn't necessarily to build a large institution. I would suggest to you the thought process really at its most foundational level was to provide a healthcare presence and a healing presence. I would posit that Catholic ministry will be strengthened when in fact we constantly hold on to that concept that we're not institutionally based, but rather we're based around the person, we're based around presence, we're based around healing from a truly holistic perspective. That, and for those clinicians in the room, my apologies for saying this, and you know, I'm an incompetent pharmacist, so I can say that. We historically, as healthcare providers, and Catholic and other than Catholic alike, have, if we're really honest with ourselves, have built our systems around providers, around institutions, around what was best for the provider and the institution first. I'm not being critical, but I would suggest to you that's probably the way we developed our healthcare delivery system. I think there's a wonderful opportunity for the Catholic health ministry because of who we are and how we view treating persons as individuals, that if we move our delivery system, regardless of the form, regardless of whether it's a hospital or a skilled facility or a home-based program, that if we're truly person-centric, that we build the delivery system around the individual, around the person, then in fact the Catholic ministry will be alive and well regardless of the form it takes going forward. The next comment I'd make is we've talked all morning about Catholic hospitals, and there will always be Catholic hospitals, I believe. But I would also suggest that, again, true to who we are as Catholic ministry, there's a wonderful opportunity to evolve into community-based services based upon true identified community need. Let's give you an anecdotal story. Someone mentioned, Barbara I think mentioned Mercy Hospital in Pittsburgh, another one of the hospitals of Catholic Health East. It was the first Sisters of Mercy sponsored hospital in the United States. As the environment involved in the greater Pittsburgh area, for those of you familiar with healthcare, are familiar with the University of Pittsburgh Medical Center, which evolved to roughly 30 owned and affiliated institutions in western Pennsylvania. extraordinarily sizable system. We, although Mercy was a part of Catholic Health East, it was truly a standalone institution within the city of Pittsburgh, and as Barbara said, made a strategic decision to stay downtown because there was an identified need for care, particularly in the downtown area of Pittsburgh where it provided services. It started struggling mightily financially. Great quality care, superb at what they did, trauma center, wonderful tertiary programs. But we got a little creative and got into a dialogue with UPMC, and eventually, and I'll use a hard financial term, monetized the asset. And what I mean by that is we sold the institution to UPMC, but we kept roughly $100 million in the city of Pittsburgh and redeveloped services that were specifically identified to meet unmet community need. And I would suggest to you that is totally consistent with the heritage of Catholic healthcare in the United States. I would also suggest that you will probably see more of that as the healthcare system itself evolves in this country. It doesn't mean that it's not a meaningful service for the community, and meaningful services don't necessarily mean hospital. They mean presence, and again, they mean how do you truly meet that unmet community need. Now in Pittsburgh, they are the largest provider of behavioral medicine in Western Pennsylvania because of that evolution. Talk a little bit about healthcare reform. Healthcare reform, as you know, CHA was very supportive of. We continue to be supportive of the reform activities. It will force Catholic institution into, I would suggest, many more partnerships, many more very unique structures. You've seen, as an example, Catholic Health West recently evolved to a system called Dignity Health, which is now a structure whereby the parent is non-Catholic, but it has both Catholic and other than Catholic institutions within that parent. Why? It certainly allows for growth. It allows for the ability to extend, if you will, the presence of those Catholic institutions into a marketplace that's extraordinarily competitive in the state of California. But it's unique. It's a very unique structure. Boston, Massachusetts. Approximately 2 years ago, Cardinal O'Malley, with the then Caritas Christi system, came to a conclusion for a variety of reasons they needed to find a partner, and eventually sold those institutions to a private equity firm, Cerebus. And now we have in the greater Boston area a for-profit, corporately structured Catholic designated system of hospitals. Now, with both of those examples, they're new, they're novel. Certainly there will be learnings coming from them, and I would suggest learnings coming from a variety of other emerging models across the country. Ascension Health has partnered again with a venture capital firm to see if there's a way to help struggling Catholic institutions. So there's a variety of models that have emerged, and I would suggest will continue to emerge, many of which will cause us to really be very introspective. Use the for-profit example. Can you be true to a faith-based mission with a special predilection to the poor, at the same time be potentially tied to a corporate structure that calls for maximizing shareholder wealth? And if you think about that dichotomy, that's an interesting question of which time will tell. Can those two interests appropriately coexist? So again, those are some examples, and if you want to chat through some other ones, we can. if you just look at what's emerging from a pure technology perspective, as well as how we're treating disease so very, very differently. I'll use stem cells as an example, and that's a terrible word in the Catholic world, but I would suggest to you we are rapidly learning that the positive impact of stem cells can come totally away from embryonic stem cells. Whether it's autologous adult, whether it's other ways of developing them, the outcomes seem to be the same. So I think the moral and ethical issue can be, I think, avoided from a scientific perspective. In fact, the Vatican had a conference on stem cells a couple months ago to look at how you can utilize them. So example, we all know that the #1 reason for inpatient admissions to hospitals on average across the country is congestive heart failure. And yet we're using stem cells to which are simply injected through a catheter into an individual where pump volumes are going from 20 to 70%. So those are the kinds of changes that I think will impact not only Catholic healthcare overall, in those things that historically acute care institutions were busy with. Over time that may change. And whether it's stem cells, whether it's genetic engineering, there's a variety, I think, of rapidly emerging, and I use the word loosely, technologies that I think will impact acute care institutions, particularly very dramatically going forward. A couple of other comments and I'll stop. One goes back to this issue of the evolution to the laity. There, again, I can talk about the large Catholic systems, the 80% roughly of institutions, and I'm sure there's more than that, have developed very, very well-respected, very frankly effective, both leadership development and ministry formation programs. Programs to help the laity, whether it's at a management level, a governance level, or a sponsorship level, to really take, if you will, those ministries, those charisms forward in a way that are consistent with the heritage of the sponsors. That's hard work. A very sage sister once told me, we know when we will get there when we can answer this third question. The first question from a laity perspective is, if there's a decision to be made, sister, tell me what to do. I think we're beyond that stage. The second question is, from a lay perspective, again, analyzing that same decision, what would the sisters do in this instance? I think we're kind of there right now. The third question, and this is when we know we will hit, I think, the point where we can feel very comfortable, is what will we do in a perspective that's totally consistent with the heritage? And so we're in that evolution right now, and it really does require not only training, but true formation. Examples. There are multi-year formation programs that many of emerging laity leaders participate in. Here's the thought around all of that with the evolution to the laity that I'd leave with you. Do the next generations of leaders, who will probably be the first generations of lay leaders who are not working side by side with women religious or other religious, will they have the capacity to look at this from a true vocational perspective? And I don't know the answer to that, but that is going to be the challenge, I would suggest, in the next 10 to 20 years. Can that vocational aspect be maintained with lay leadership at all levels? And then finally, I'd just say the challenge of church implications, we're living them right now. You can't pick up a paper without seeing the challenges and the struggles that are going on with respect to contraception mandate right now. The thought I would leave with you is, if we stay true to our principles, and regardless of the controversy right now, regardless of the debate right now, I would suggest all of Catholic parties involved in that debate are being very true to those principles. I don't think there's any issue with that at all. How we get there, I think, is the challenge. And I said this to a few people earlier. We're not of the Amish faith, as an example. We don't retract from the world. We dive headfirst as Catholic ministry into the world. And at times that can be messy. And at times that can cause controversy. But we are a dialogic culture. That is the foundation of what I believe Catholic ministry and Catholicity is all about. To be dialogic in our decision making, to be relational in how we interact, and from that, my hope is we will always end up with the right outcome, always consistent with the principles that we hold dear. So let me stop there. Those are sort of at least some thoughts of where I think Catholic healthcare is going. Again, one person's opinion, so Tim, thank you.
Our panel is open for questions, some dialogue even from ourselves. So thank you for your expertise for all three for being here.
I'll start off by thanking all of you for really useful perspectives on some of these perplexing issues. And as I was listening to you, I was jotting down some thoughts, and I have a question, I suppose, for all of you. If what we're about is healing, and if what we are focusing on as we move forward into the future is healing, what is the balance we should be seeking between health care and health? Because they're not the same thing. And I think a lot about the poor in this country who become ill because they lack the ability to produce health, because of mental illness, because of plain lack of access to education, to the means to keep themselves healthy. Where do we find the balance moving forward in Catholic healthcare between engendering health in communities and simply providing high-tech health? And I appreciate your thoughts.
Here you go.
That's a great question. Let me just give you one little piece of sophomore erudition, which I mentioned to Tim and my friend at Washington Hospital Center yesterday, yesterday I guess it was. Remember I said, Rick, when you were a sophomore at St. Joseph's Prep in Philadelphia, that you knew that the Latin meaning of salus could be health or salvation.
I think that we focus so much on curing rather than healing. And there's a world of difference in the two. If we can keep the healing part of our mission to promote health, well-being, prevention, the healthcare part of it is going to change and move so much more from the acute model to home and community-based. If you just take a look at what the White House is trying to do with providing good food in public elementary schools, to exercise, the whole keep moving philosophy, focusing on prevention and wellness. you'll see less and less of the health care and more of the health.
You know, we have a delivery system that, from a variety of different perspectives, not only read this as financial, a variety of different incentivizations around treating disease. We actually have a system that at its core is treating disease, not preventing disease from occurring. There are many components of the Affordable Care Act that attempt to reverse that, to put emphasis into the prevention of disease and to incentivize that for the first time. Because that really, I think, is the key for us to make that evolution. The second comment I would make is so much of disease and the prevention of disease is not related to what we typically think of health, but it's related to housing, it's related to living conditions, it's related to food, it's related to lifestyle, obesity, all those things that if you really look at it from a socioeconomic perspective, I would suggest we need to place much more emphasis on that, particularly with the underserved and poorer population bases, because that is where I think you can make a dramatic dent. And then reversing this cycle of spending extraordinary resources saving versus spending a fraction of those resources preventing. So it's a mindset change, but I think it's an incentivization change that we have to make sure we get finished with the Accountable Care Act, or else we're going to have issues again.
I think you need a lot of resources in order to be able to successfully implement community benefit programs. And the challenge is going to be with, you know, where's the money coming from in order to sustain viable health centers in the community to take care of the immigrant population and those who don't have health insurance, those 30+ million I talked about earlier. Other than the models that, I'm sorry, I forgot your first name, Bob talked about, where the for-profit entities are having business arrangements with Catholic Health, most Catholic institutions are not-for-profit status. Although they can earn a profit, where does that profit go into in order to maintain their tax-exempt status? Well, you know, my belief is it should go into the community and to help service this population. But that means that with decreased reimbursements to hospitals, you know, that leaves your profit margin really slim. Where does that money go? I think that the statistic Bob showed about more and more Catholic hospitals becoming part of systems is one way that you can benefit. I know at Trinity Health that certainly was a big plus for Holy Cross Hospital, being part of Trinity Health and being able to count on a larger organization assisting with finances.
The only other comment I'd make to that is watch the federal government, because I think there will be, in time, a renewed interest for not-for-profit, tax-exempt organizations, whether they're hospitals or anyone with that structure, to be able to more objectively demonstrate why they enjoy that status, and that goes directly to community health to a very large degree. You know, there's a lot of studies out, and you'll see some that are, my opinion, more anecdotal more than anything else, that people who experience spirituality in their healing process heal more rapidly. People who pray heal more effectively and rapidly. When you see those studies, are they extraordinarily well done scientifically? I can't answer that. Is it dramatic? I can't answer that either. But I do believe that we're beginning to learn more and more that when you do look at body, mind, spirit versus just the typical clinical approach that we've done in our Western society, that in fact there's probably a lot that we don't understand yet. Now, you're going to get a grant for that? I don't know the answer to that. But that's really one person's opinion.
I think this touches your question. I'm going to deliver a manuscript to the Georgetown Press this week. It has 8 essays in it, and all the essays address the question about to what degree should we hope for health from science and technology. The particular protagonist that we're working to defame is the World Transhumanist Association. And the World Transhumanist Association has this formal oath, so to speak, that it's only a matter of time before the sciences and technologies will deliver all of the things that the religions incited people to hope for. Now, the 8 essays are all addressing that vaunt, but not addressing that vaunt in a way that does not see the sciences and the technologies as central to healthcare. They are central to healthcare, but they are not going to deliver the eschatology. They're not going to deliver the kingdom. So it's an important issue, this relationship between the mission of healing in Catholic healthcare and science and technology. What exactly is that relationship? And this book, I think if the publisher goes along with it, will be called The Wither of Transhumanism, Spring or Winter. In other words, where is transhumanism taking us? Anyway, that was a little advertisement for a book to be.
As far as statistics go, I think in a few years we'll be able to take a look at the results of what the Medicare program recently has introduced, which is payment for PSA tests, towards prevention of prostate cancer in men, and payment for an annual mammogram for women over the age of 65. But those are fairly new provisions, preventive provisions, and in several years' time we'll be able to see if indeed those 2 tests have succeeded in dropping down the incidences of prostate cancer and breast cancer. I think is a little too soon. So many of the, unfortunately for you, the numbers are anecdotal numbers. They're story-based. They're rather than science-based. But I think in several years' time, we will be able to see some movement, hopefully.
The one comment I'd make is, I think the healthcare systems, and I probably sound biased with that, that's where I've come from, but I do believe the healthcare systems have now begin to demonstrate the true value they bring to their local ministries. In the beginning of healthcare systems, it was resisted horribly because, the old issue of local control being lost and all those dynamics associated with that. We probably as systems made a lot of mistakes around that too, to be honest, but I think we've learned how to maximize the value of systems without compromising the local impact of a local provider. Sure. There's a wonderful place for Catholic ministry to do that. One of the areas where if we can ever get successful politically because of some of the prohibitions from an ethical perspective that stop us from getting involved is in the federally qualified FQHCs. And unfortunately, there are some moral objectionable things that are still mandated, but I believe that's one example of where we can truly partner with the government. I would also say that there are hundreds of examples across the country where Catholic providers, primarily hospitals, have partnered in a variety of different fashions with local communities, with volunteer-based organizations, with nurse practitioner-ran community health centers. There's a variety of those, and again, if you want to access those, get in touch with CHA because they keep a pretty good compendium of best practices. I'm sure they'd be willing to share that with you. There's a lot of models out there, and they're very effective. It all goes back to that community need issue, too. Yes, yeah, absolutely. As I said before, I think there will be Catholic hospitals, and they'll be very strong, as they are now, but I think all of healthcare will continue on this evolution to more and more community-based. We can't afford as a society to treat so many people in the most expensive vehicle and institution to treat people, and that's acute care hospitals. If we can, the pure economic savings and what I would suggest the tremendous improvement in health because of continuity of care is to take people out of an emergency department and get them into some type of a primary care setting where there's continuous care, where there's ongoing, the impact from a societal perspective is huge. So those are the kinds of things that, again, I think the Accountable Care Act will, in fact, hopefully help us proceed with.
Two comments. I think if you look at Jesus of Nazareth getting stretched in his public ministry, getting stretched by being importuned by need, so that he went beyond a self-understanding that was Jewish to a self-understanding that enabled us eventually to see him as Savior, those of us who believe that. I was interested when Bob said something to the effect that concern for care, the care of the sick, will stretch us beyond all of the institutional sectarianism we have been part of in our past, and move us, I think, exactly the same way it moved Jesus of Nazareth. When the Syrophoenician woman came to him and said, "Look, buddy, you got it. My kid needs it," and he says, "Look, I don't work for non-Jews," and she said, "You got it. The dogs with the food under the table and all that stuff. Look, my kid needs it," and he went and healed his child, her child. I think in the same way that this stretching because of need will stretch the church into a real Catholicity rather than a Catholicism. And I think the healthcare, the Catholic healthcare institutions are more forerunners of that for the rest of the institutions of Catholicism than any other crowd.
Again, I'll try to give you an anecdotal story about that. Those of you familiar with healthcare have seen that with the change of sponsorship from the religious to the laity, we have now evolved into canonical structures, not civil, but canonical structures known as public juridic persons. And some of you are familiar with those. And I'll tell you a story. We had a public juridic person for about 10 years. Interestingly, it was one of our sponsors. It wasn't the sponsor for the whole system. It was just one of our many sponsors. And we would go to Rome every couple of years and report on our public juridic person. The Cardinal Rodet, for those of you who know the hierarchy in Rome, at the last meeting I was at, looked at everyone and was primarily, there are still some religious involved with this new sponsor, but primarily lay, looked at everyone, and he actually spoke in English too, which was very telling. That was very symbolic, and said, "You need to know you're the future of the church." Now, if you reflect on that, Tim, I think what the church is telling us through that message is, in fact, it's a very, very ecumenical church that hopefully is evolving. And again, I agree with Father. Because of the history and heritage of how Catholic healthcare started and where it is evolving to, it's kind of leading that way out of necessity, if nothing else. But we're kind of leading that way in that true ecumenical of the church and how we're evolving as Catholic healthcare.
I'll just give you one little personal anecdote. When I was asked to serve on the Board of Trustees of Holy Cross Hospital, I said to some of the sisters and the president and CEO, "Are you sure you want a young Jewish girl being on your Board of Trustees?" And they said, "Not only do we want you, we need you." And it was because of the mission of the hospital, which also was part of Trinity's mission, just really was extremely meaningful to me. More so, and I had been asked previously by other institutions to serve on their boards and declined. But the mission of Holy Cross Hospital and Catholic Health just was enormously important to me. It really touched me. So that's just a personal story.
One last little comment. The gospel this Sunday is from Mark, and these guys bring this paralytic, and the crowds are so thick around Jesus that they have to carve a hole in the roof to put him down so Jesus can heal him. What's interesting to me was one line in this gospel, Sunday's gospel. Seeing their faith, the faith of his friends, he made the man whole. I think in many ways, the witness to faith that a Catholic hospital can be makes many whole in ways that the absence of such a witness would not. It would be a totally secularized thing, this healthcare world. And that would really be culturally, religiously disastrous if healthcare was reduced to the imminent prowesses of professionals